Naresh? Okay. Naresh, are you there? இது அந்த ஸ்டோருக்கு போயிட போறாங்க. Naresh, am I audible?
Yes, sir.
Voice clear?
Yes, sir. Vignesh, sir,
Okay, super.
I can hear you. Yes, sir.
We will start by 7 o'clock, okay? You're calling in the phone.
Naresh, am I audible?
Yes, sir. You are audible.
Okay, thank you. Sir, welcome, sir. Arnachalam sir is joining, sir. Already informed. In couple of another 5 minutes, sir will join, sir.
Yeah, okay.
Sir, good evening, sir. I'm Kumar.
Good evening.
Good evening, sir. Sir, I think Mohan Mani sir read to join.
Ah,
Actually, first speaker, Assis sir, is already here, sir.
ah, ah.
Okay, so shall we wait till Mohan Mani sir in, or how we'll do that, sir?
So we'll wait for 5 minutes, huh? Huh?
Okay, okay, okay. So, Assis sir, actually, shall we wait for 5 minutes?
Yes, sir. Yeah, we can wait.
Okay, no issue, no issue.
Madam join.
Arnachalam sir, good evening, sir. Dr. Aziz.
Good evening, sir.
Yes.
You're from Coimbatore, sir?
No, sir. Actually, basically, I'm from Chennai, but now settled in Neyveli. NLC Kaveri. Yes, sir.
Oh, right.
Yes.
Hello, sir. Sir, actually, sir, 2-3 minutes will join, and Cecily Mary Madam is already joined.
Oh. Okay. Madam join பண்ண மாதிரி இல்லையே. Ah.
I joined. Maybe my name is not reflected over there.
Hi, ma'am. Hi, ma'am.
Hello. Hello.
Good evening, madam.
Good evening,
Hi,
sir. Good evening, sir.
Hi, ma'am. Sir, I think actually we can go ahead, sir. I think we can start, sir. I think so. I think a technical team is already recording start. Hi, Vijay, sir.
Hello.
Naresh, are you there? Recording started. Okay, sir. Arnachalam, sir, please start, sir.
Okay. You able to see my slides now? Huh? Hello?
Yes, sir. Yes, sir. You're able to see
Yes,
your
sir.
slides. Yes.
Good evening, everybody. First of all, I thank the Abbott people, and also I thank Cecily Madam and Mohan and all the presenters, including Vijesh and Mohammad Aziz and all the. Good evening, all. So I'll be sharing a few slides about the guidelines for CCS and ACS imaging guided management. So we all know that class 1 is the definite recommendation, that is it is beneficial, and A means it is supported by one RCT or meta-analysis or high quality RCTs. So if you look at this recommendation, OCT or IVES, that is imaging guidance PCI, which are anatomically complex like left main bifurcation, true bifurcation and long lesions. These 3 subsets, definitely imaging guided has a class 1 recommendation by reducing the MACE events, which is supported by large body of data. Almost 14,000 patients have a data with intravascular imaging, which supports better patient outcomes, starting with Illumian 4 trial, which is a OCT guided PCA versus angio guided PCA in complex cases, around 2,500 cases. October, that is in bifurcation, angio versus OCT in 1,200 patients. And Optivus is comparison of OCT versus IVUS. And network is again a comparison of OCT, IVUS versus angio. And Occupy is OCT guided PCA versus angio in complex lesions. If you look at this, the results for imaging guidance compared to angiography alone, this is from NEGM Ziautali. This you see that the OCT, you can see that 5.72 is the MSA, while angiographically 5.36. The p-value is significant, and you have 7% increase in MSA by OCT guided, which results in reduction of major dissections, malapposition, and tissue protrusions. Finding out that whether if there is a more lipidic clot, better not to predilate that, and if there is more protrusions due to thrombus or mixed, we can keep the balloon at a low inflation pressure and can reduce these protrusions and all. So again, from Illumian 4, you see that angio was OCT guided. You see that the angio guided PCA has 1.4% stent thrombus. If you come to OCT guided PCA, it is 0.5% only. There was almost 64% reduction in stent thrombus rate, because 95% of patients develop either death or MI within 2 years when stent thrombus occur. And again, in Illumian 4, you see that regarding cardiovascular death or TVMI or stent thrombus, it is 4.9% in angio arm, and compared to the OCT arm, it is 3.1%. Especially in these subsets where the stent length is more than 28, or there is severe calcific disease, or when there is instant restenosis or bifurcation or CTO. Because in such complex lesions, if you use OCT, it results in larger MSA, greater stent expansion, and reduced MACE and reduced dissections and malappositions. And from October trial, again, you can see that OCT guidance in bifurcation met the superiority primary endpoint when compared to angiography. You see the y-axis, the MACE events, it is 14.1% for angio-guided PCI, which reduced to 10.1% with OCT guided. There is almost 28% lower major adverse cardiovascular events with OCT arm in 1,200 patients with 1 year results from October trial, especially in bifurcation lesions. And we see that again, the safety of OCT guided PCI, the all-cause mortality, cardiac death, target lesion, all are reduced in OCT arm when compared to the angiographic arm. And from Optivus, OCT versus IVUS trial, if you see that the results are comparable when it comes to the target vessel failure or like cardiac death or target vessel MI or target vessel revascularization, you see that IVUS arm, the events in 2000 patients is 3.1%, while in OCT arm it is 2.5. The p-value for non-inferiority is significant. So that shows that both IVUS and OCT are safe. Even when you even compare with the complications due to there is a contrast usage in OCT, but doesn't result in increase of contrast nephropathy in this Optivus trial. This network study, this shows that imaging guidance improves patient outcomes. This is from that meta-analysis of 12,500 patients of over 20 trials of OCT or IVUS with angiography alone. You see that in this meta-analysis, all TLF, cardiac death, all-cause death, MI due to target vessel or all MI or stent thrombus or target lesion, all are favoring reduction when you do image guided when compared to the angio guided PCR. And again, if you see that from this Renovate complex, this the image guided PC clinical results, you see that this is first one is OCT guided. You see the angiographic guided PCI, the MACE events are 12.3, which is 5.8 with OCT guided. When you come to the IVUS arm, again 12.3 with angio is 8%. But when you compare both IVUS and OCT, it is not much, p-value is not significant, 0.24. But when you look at the OCT versus angiography and IVUS versus angiography, the p-value is highly significant in reducing the MACE events. Then this is Occupy trial, which is nothing but a OCT in primary complex lesions. The results will likely change the practice of PCA with this, especially for complex PCA lesions. And the objective is the trial investigated whether OCT is superior to angiographic guided for PCA clinical outcomes in patients with complex coronary anatomy. And the study population from 20 centers in Republic of Korea, the 1:1 randomization. See the primary endpoint. You see the composite of cardiac death, MI, and stent thrombus rate at 1 year is reduced by 38% in OCT guided arm, that is 4.6, while it is 7.4 with the angio. Then come to the secondary endpoints like spontaneous MI, it is 2.4 in angiographic arm, while 0.9%, almost 64% reduction. And come to target vessel revascularization, again, angiographic arm, it is 4.1 and it is OCT 1.5. That is the TVR is reduced by 64% in image OCT guided arm. And we come to the tactics registry. This is a Japanese registry to identify the objective is the prevalence of the cause of the ACS using OCT, the morphological assessment of the culprit lesions, followed by the outcome of the lesions. So all the ACS patients who are OCT guided primary PCA were taken for tactics registry. And you see that the morphology, what they do is they first do a thrombus aspiration, and if needed, do a small pre-dilatation with a semi-compliant balloon 2 millimeter, or they do excimer laser, because this doesn't much affect the morphology except the to acquire OCT, because the lesion is tight, you may not get complication. If thrombus is more, the clearance will not be good. So the laser also helps to vaporize the thrombus and can make the OCT images better. So to find out the underlying causes of ACS and further lesion preparation. So the morphology, for example, if it is more lipidic, no need of much preparation. If it is calcific, we can targeted area can be pre-dilated. We need not just predilate, diffuse, and get into slow flow, no flow, and all complications. When come to the sizing, we can find it out the reference site with the least lipidic plow, because the landing zones, say the takeoff or landing zones, if the landing zones are less lipid, the restenosis rate is less, the dissections are less. And stent sizing, this can be better with Altium 20. You can get the lumen and EL from the throat, the run, and you can choose the easily the stent based on the distal EL lumen and proximal EL and lumen. And finally, the optimization, that is you can get a Timmy flow, we can get a less protrusion of these tissues. Protrusion can be reduced, and you can get a good the stent, the lumen area of at least more than 4.5 millimeters square without major dissection, malapposition, or protrusion of tissues or thrombus. So this is the great advantage of the OCT guided in ACS. And optimal registry, the study is from 8 centers in China, almost 6,000 patients, 2,000 with OCT and 4,000 with the angiographic alone. The MACE events at 1 year, yet to come in December. The all-cause death and cardiac death, this is what looking at this. And Atlas OCT is nothing but ST elevation, acute myocardial infarction, clinical outcomes treated by optical coherence tomography guided PCI. It is an investigator-initiated prospective all-comer trial, multi-center trial in around 16 institutes. And you can see that the feasibility of OCT-guided PCI, 78% and 20% non-preference for OCT because of the patient hemodynamic status or the diffuse lesions or more thrombus and all. And the components, you can see that they could do a morphological assessment, 70% stent sizing and stent optimization. So we all know that in calcium lesions, left main, definitely imaging is needed. Bifurcation, yes, imaging, the proximal cross, distal cross, and also looking at that whether the angle is that BPCT, that is a bifurcation point to carinal tip angle and the carinal angle. All these things helps and to get good results, either decay crush or in other type of bifurcations. And we know left main, definitely the sizing is very important because there should not be a floating stent in the left main compared to the thing. Many times we think it is 4, but many times 4.55. And so definitely in left main bifurcation, in long lesions, yes, because you have to know that you have to try to avoid long stents, and we have to find out diffuse lesions. You might land in a fibrocalcific because you get a diffuse lesions. But now the catch up is OCT is now with Atlas OCT and the registry and all. You can see that in ACS also there is more benefit, but the thing is it should be individualized. So to conclude that over 12,000 patients with a solid data in imaging guided PCI, and you can see the superior outcome for imaging guidance compared to angiographic alone. For example, that is a 31% reduction of TLF, cardiac death, TVMI, TLR, and you can see the safety benefits of reduction of stent thrombus, all-cause death. And when come to the OCT, which improves the procedural and patient outcomes, you can see the MSA, larger MSA, greater expansion, and you can see less dissection, malapposition, tissue protrusion. But when you compare IVUS and OCT, it met only the non-inferiority criteria, and still the contrast usage was higher with OCT, but doesn't results in more increase of contrast nephropathy. So there is no much thing CAN is increased with this contrast. Thank you.
Thank you, sir. It was very useful updating the guidelines for all of us. I think in primary PCI, I think it will have more and more a role, especially in youngsters, whether we need to stent or not, whether the whether there is an ulcerated plaque or not. Sometimes, definitely, I think in the near future, I think more and more will be start using it for even acute primary PCA. What is your take, Mohan sir, on this for primary PCA?
Madam, good evening, everyone. The main thing is actually, as you said, Madam, nowadays, if you do the angiography alone, then the risk of missing or risk of dissection, which is missed, then later on getting a stent thrombosis and patient dying, and suppose that mala position which has been missed angiographically, when you see look at the imaging, then you can see that again a mala position with there. These are all the problems are very common when you do the angiography alone PCI. But when you move on with the image guided PCI like OCT or IOS, but OCT if you do it's a more colorful image. You can get everything on that thing. You can understand easily because IOS has a long learning curve. But nowadays IOS also been bit improved actually compared with the previous thing. But the easy all the youngsters which can easily can absorb is OCT. They can understand very easily. The learning curve is less. All long lesions, bifurcations, CTOs, calcific lesion, which is already proven. Now move on to the other thing. Routinely we have to do, yes, compare with angiographic alone, yes, OCT have a upper hand. When you do an image guided PCA, it has its own value.
Yes, apart from all the factors, conditions where Dr. Arunachalam sir had mentioned, I would like to emphasize that there should be guidelines for vulnerable plaque, especially in youngsters. Vulnerable plaque assessment by OCT, and nowadays newer articles have come on whether we need to put in a biovascular scaffold in such patients so that to prevent sudden cardiac death. So the OCT imaging, there are for vulnerable plaque, not only the thin layer, not only the thin cap, the microns, that is alone not important, because that alone does not determine whether it's a vulnerable plaque or not. Whether there is micro calcification or spotty calcification, whether there is an increased vasculature in that plaque, or whether that will be or a rise in temperature, which will suggest that this plaque is going to rupture in the near future. That would be the future of OCT in a vulnerable plaque, especially in youngsters. We should do it routinely in a lesion which is around 50 to 70%, which we need not do routinely as stenting, but do a OCT for that vessel also and see whether the vulnerable plaque is going to rupture. That risk is there, which consists of lot of characteristics, not only the thin layer alone which is going to rupture, but the other factors which tells that this plaque is going to rupture or an impending rupture, and put in a biovascular scaffold if necessary, or else put them on high dose statins and all the preventive drug regimens. I think that has to be included. My few words, guidelines should come for that also. So thank you.
No, exactly correct, madam. Because everybody will talk about the TCFA, the thin cap fibro, which is 60 microns and below, which is already been proven as
Yes,
a
yes,
for the plaque rupture. But as you said, there is a microspotty calcification where there is a micro channels which is having the
new vasculature.
rising the
Yes,
temperature, having the neovascularization, producing the rupture. Those are all the thing as a future, madam. Definitely, it has
Yes,
to
sir.
be, yes, madam. Correct,
Actually, the thin cap fibroathyroma less than 60
60.
microns. Now that criteria, that is not an important factor for plaque rupture. In the recent studies, they are telling this
Yes.
spotty calcification, increased vasculature, new vasculature, and the change in temperature, which could also be picked up by using artificial intelligence into OCT. That would be the future of OCT in detecting this impending plaque ruptures. I think
Yes,
that would be the future, and it will be very helpful also.
Good evening, all.
Yes, sir. Good evening, sir. I think we can move on to the
Move on to the topic specific.
Yeah.
Yes.
yeah.
So next, Dr. Mohammad Aziz, you will be proceeding the case now. Huh? Hello?
Sir?
Yes, sir. I'm available, sir. I'm audible, sir?
Yeah, you're audible.
Okay.
Yeah.
Yes, sir. Good evening to one and all. Special mention to Dr. Arunachalam, sir, Mohan, sir, and Cecily ma'am who is chairing the session. And I would like to also thank Abbott for giving me this opportunity to share my experience. I would like to share my presentation. Is the presentation visible, sir?
Yeah, visible.
Yeah.
Okay. So I had a patient who is a 55-year-old gentleman. He was hypertensive, had a previous history of CVA. He had a anterior wall MI in 2024 April, underwent a primary PC angioplasty elsewhere, and presented now with complaints of chest pain. He was compliant to medications. I did a ECG showed ECG was non-specific, some T inversion in the anterior which was there already before. Echo was some mild LV dysfunction which was also already there before. So I did a treadmill. Treadmill was strongly positive. I did an angiogram. Angiogram showed there was a stent in the proximal LAD just inside the ostium. It showed an LAD ISR, and the size of the LAD was angiographically looked around 3.25 to 3.5. I initially thought there was a gross undersizing of the stent during the primary PCI. There was no post dilatation notes also. So I thought I could get some more information on OCT, whether to just do a post dilatation of the previous stent, or if there is any geographic miss or something else to be identified. So this was the I wired the lesion and then did the cutting balloon initially with a 2.510 and
Ajit,
went ahead with the OCT.
your slides are not moving.
Sir, slides are not visible, sir.
Yeah, no, only the introduction.
You didn't
slide.
do the slide share. Your slide is showing, but you have to put that mode, slide share mode.
Sir, is the slides visible now?
Yeah, visible, but you can put the slide share mode, the last one. Huh?
The last one, there is a slide.
Sir, just a minute, sir. I'll just.
Okay.
Sir,
yes. Okay.
Now?
Yeah, able to see that.
Yeah. So this is the baseline. Yeah. So this is on the left side, you could see the first angiogram is the baseline angiogram. You could see that stented segment proximal ISR is there. And I decided to predilate because the lesion was very tight before doing OCT. I straight away, because I thought we could take a cutting balloon, 2.510, and predilated and did an OCT. OCT showed, this is the OCT run. Can you see the OCT run?
Yes.
Yeah.
Yes.
So we could see, yeah. So we could see there is a gross geographic miss at the distal edge of the stent, this region. Yeah. Then the stent starts, and there is adequate cuts done by this 2.5 10 cutting balloon in the 3 o'clock to 6 o'clock position, and also there was a gross under sizing of the stent also. So the distal stent beyond the stent edge was the vessel size of 3.5, and the stent expansion was adequate, but it was an undersized stent. So patient subsequently developed a neointimal hyperplasia. And this, you could see the distal, the first video, you could see the distal. Yeah, distal lesion is missed there. You can see the neointimal hyperplasia. In that, the MSA was very small, 2.2 area only. The right image, you could see that right video run, you could see there is a proximal edge also landed on a block. And these were the cuts made by the Wolverine cutting balloon. In the OCT images, you can see in the 3 o'clock position, there is a well-defined cut. It is not an NC balloon would make gross major kind of dissection, and this was a controlled dissection by the cutting balloon. And you could see the MLA of only 2.25 millimeter square at the beyond the distal edge. So now my strategy changed. After seeing the OC, there was a grossly underexpanded stent. Distal and proximal edge both were land on a block, and the distal edge had a MSA of 2.25 beyond the stent. So I decided to place a stent distally as well as the proximally, and post dilate the previous stent. Since the plan suddenly changed, the patient is not financially fully prepared for that. So I avoided doing a drug-eluting balloon for the previous stent. If I had no major dissection in the stented segment, or there is no other abnormalities in the previous stented segment. So I went ahead and did the first NC pre-dilatation of the previously stented segment, and you can see there's some waste here of the proximal edge. This is mainly because of the fibrous plaque on the proximal edge of the stent. And ultimately, anyhow, I plan to stent the proximal as well as the distal. So this is the distal stenting of the distal edge ISR. I used a 3 cross 16 mm drug-eluting stent, and the proximal I used a 3.5 cross 8 mm drug-eluting stent. So after the stenting, this is the final OCT image. You see the stent has been well expanded. There is some tissue prolapse noted there and some dissections noted there, but no major flow limiting dissections there within the previously deployed stent. And the proximal stent came up to the ostium of the LID. There was no major edge dissection and no geographic miss at this time. The distal stent area was about 5.2, mid was MSA was about 7.3, and proximal was about 7.6. So I was happy. I think I hope that the patient doesn't come back, because I had given a good result this time. This is the final image. Sorry. Patient got, actually this case I did day before yesterday, and he got discharged today. And any questions? I'm ready to take. What is your view? What plan? Anything else could have been done? Any change of strategy from this, sir? Ma'am? Hello, sir. Am I audible, sir? Hello.
Yeah, you're audible. You are audible.
Yeah. Your take on your views on this case, ma'am, sir. What else could have been done? Any other strategy you could have used? Because I had to change the plan after seeing the OCT. I had stented the proximal as well as the distal, because I was not comfortable with the on where the stent landed. It was on a block, as well as the distal edge beyond the stent had an ISR, and the MSA was only 2.2. Proximally also, I could not do only depth there, because it was near the ostium, so I had to stent that too.
Yeah, it's well done, and in ISR, it has to be always imaging guided. There is no doubt, and you have done nicely. And another thing is, with a single layer of stent, its restenosis rate somewhere around 8%, means when you put a double layer, it goes to 20%. That's the one alarming thing. But whatever you've done is like, okay, but you have both the components, mechanical expansion also there, and the neoatherosclerosis also there, and the edge also, distal edges, they are landed in the block. So you have to definitely put one stent down. So the proximal also, you felt in fibrous, it landed, so you're taken. And aggressive dilatation and all, but still after that, you can see that in OCT, there was some sandwich between two stents. But still the MSA is good. Nice.
Here you have done a 2 drug-eluting balloon, right?
No, stents.
Oh, okay. I thought it's a drug-eluting balloon. The thing is, one thing for ISR. Anyway, ISR is classical indication for OCT. No question at all. To know the morphology, why it has been happened, to identify that what is the modified migrants classification. This looks like a type 1 multifocal. Type 1 multifocal. This comes under that group. So the thing is, what you can do is, you have taken a 2.5 mm cutting balloon. Instead of that, you can do the 1:1 balloon dilatation, which is ideal for all ISRs. When you are taking a cutting balloon or scoring balloon or anything, no problem. But you have to take a 1:1. Any ISR, that's a protocol. So suppose you think that vessel size is close to around 3 mm or a 3.5 mm. You take a 3 mm cutting balloon or scoring balloon, you do the scoring or cutting, then you do the your PCA work. It will do excellent result. You will get it, because all ISR only one rule: maximum gain, late lumen loss. So maximum gain to reduces the late lumen loss. This is only protocol in ISR. There's nothing else.
Yes,
And
sir. Actually,
for
I
that,
yes, sir.
but it's very good.
Actually,
End result is very good. No question.
The least. Thank you, sir. Sir, the point is well taken, sir. But actually, what I did was first initially lumen. I took a cutting balloon. Instead of making a gross dissection, I wanted to make a control dissection. Then did an OCT, and then I took another 1:2 cross 12 LC. Then I covered the edges with a differential.
It was a great case and well done and very good results. One theoretical possibility: suppose this patient comes to you again with an ISR with 2 stents inside. What would be your protocol? How will you manage that?
CABG, madam.
Okay, first one option
Madam,
is
one thing,
CABG. Second option is
because you told very clearly, madam, all ISR, whether you do image guided PCA, image guided ISR PCA or non-image guided ISR PCA, only the time will get a difference only. Otherwise, you will definitely get a restenosis. There is no question at all, because you are doing highest cases, madam. So obviously you know the thing. Even you do a image guided PCA or non-image guided PCA, the restenosis rate will be high. Only thing, you can reduce that time period in the by imaging, doing the imaging. That's all.
we can buy some time. That's one. But
Yeah.
still, of course, if the patient comes
Balloon
again,
dilatation can be done.
yes, sir.
Drug-eluting balloon.
Yes, sir. Drug-eluting balloon is definitely an option. But suppose the osteoproximal LAD 100% occluded, definitely CABG will be the first option. And now time again, now we have this brachytherapy. Brachytherapy is now coming into place, wherein instant restenosis, we have already 2 metal struts in situ. Brachytherapy is now coming and has got a great role which was done previously. Now it is evolving, and we have to always keep something also in mind, which is relatively cheaper, affordable for the patient. And brachytherapy, that depends upon the size of the stent, how much brachytherapy should be given. We have forgotten about that, but that also drug-eluting balloon, brachytherapy. If at all osteoproximal LAD 100% occlusion, first option would be CBG. That would be the correct option for this patient.
The thing is, there is no role for third metal.
Yes, sir. Yes, sir. Third
Another
metal,
thing,
you have to avoid.
Arnachalam sir is having laser, so he can lace the entire beginning structure. So he can put the.
No, if it is inside the stent, we can try a laser and depth. Madam told we can have by, but no third metal layer. Definitely
Third
CABG
metal
or
layer,
brain.
correct, sir. Yes, sir. That would be the correct thing. No third metal layer. Either depth brachytherapy or osteoproximal LAD 100% occluded, send for CABG. That would be the right option. Yes.
Sir, we'll go to the next speaker, Dr.
Yes, sir.
Sivapalan. Are you ready? Dr. Sivapalan from Royal Care Hospital, Coimbatore, will be presenting next interesting case.
Good evening, sir.
Yeah, over to you, sir.
Audible, sir?
Yeah, you're audible.
Good evening, seniors and colleagues. This is an interesting case which we have done a month back. So it's a story of 67-year-old male who is pre-diabetic. Actually, he had a sedentary lifestyle, but his wife underwent CABG a few months back, and he started walking along with his wife after his surgery, after which he started developing effort angina. His clinical examination heart rate was 90 and BP was 130/60, and cardiovascular examination revealed no significant findings, and ECG showed T wave inversion in V3 to V6. Echo showed regional almost abnormality in LAD territory with EF of 49%. and his TMT showed stay positive in stage 1 itself. So he was taken up for angiogram. The angiogram showed a significant calcified lesion in the medial AD, almost 99%, followed by subtotal occlusion. And the OM circumflex had a one major OM with 70% osteoproximal stenosis. Nausea was non-dominant. So after discussing with the family members, he was taken up for a image-guided PCI. The plan was pre-dilate the medial AD lesion, then do an OCT run, then decide about that method of plaque quantification either by scoring balloon or rotablation, then do a stenting. So initially we took a 1.2, the lesion was crossed with the BMW guide wire, and but the balloon didn't cross. Hence, a guide extension catheter was taken in. With that support, the balloon was taken into the medial AD and done a pre-dilatation with 1.26 mini truck balloon. Followed by 1.5 by 10 semi-compliant balloon was attempted to pre-dilate the lesion, but the balloon didn't inflate. Hence, we straight away took a 210 NC balloon and did a pre-dilatation in medial AD. After that, the check angiogram showed no flow phenomenon. The patient developed chest pain, bradycardia, hypotension, and monitor showed ST elevation. Hence, a 2 dose of atropine and NORAD infusion was started. The same 210 NC balloon was used to daughter the thrombus to the distal LAD, but the attempt was failed. The NC balloon was intentionally punctured to deliver the drugs like teriflunomide and nicorandil distally, but the attempts were failed. Patient continued to have chest pain. Hence, we took a fine cross microcatheter to distal LAD, an intracoronary elaxium and adrenaline was given. Within a minute, the flow was established. Chest pain reduced and hemodynamics improved. An OCT run was attempted, but approximately the OCT catheter, the camera didn't cross. Hence, we did a pre-dilatation with the aperta balloon, 3 by 13 aperta balloon. We did a pre-dilatation sequentially from the proximal to medial AD, followed by pre-dilatation with the 310 NC balloon. The check angiogram showed a micro dissection in the proximal LAD. Hence, we decided to stent the proximal LAD to seal the entry point of dissection. This dilatation with aperta balloon, initially it showed a dog bone effect. With the continued pre-dilatation, it gave away. A 3 by 33 drug-eluting stent was positioned from the ostial LAD to medial AD and deployed. The OCT run showed a deep-seated calcium with a fibropathic block in the medial AD and a malopposition in the ostial part of the stent. So the medial AD showed eccentric calcium behind the stent, the distal deep eccentric calcium, and proximal malopposition. Post-dilatation was done with a 3 balloon and a second stent 2.5 by 38 drug-eluting stent was positioned in the medial AD with overlap with the proximal stent and deployed. Then post-dilatation was done with a 2.75 NC balloon. We did a check angiogram which showed a small haziness beyond the second stent. Hence, we did a small OCT pullback which showed a large intramural hematoma distal to the second stent. So this was a large intramural hematoma distal to the 2 millimeter distal to the second stent. Hence, a third stent, a 2.25 by 15 drug-eluting stent was positioned across that lesion and deployed. The final angiogram showed symmetry flow with no residual haziness or thrombus, and the patient was quite hemodynamically stable. Thank you, sir. Any comments or opinion, ma'am?
Yeah. Thank you, doctor. It was great case, well managed. But the right thing as you did that, whenever medical management in the slow flow, you have to always wait. And the right thing, you had given adrenaline low dose as well as what else have you given, doctor, for the distal flow?
Intracoronary laxin, ma'am. 1/5 of the calculated dose we gave intracoronary.
Okay. What is the guidelines? You have any guidelines for that, doctor? It's correct. It's correct. What you've given is correct, but I just wanted to ask you. What is the guideline? How much maximum dose you can give intracoronary?
1/5 of the calculated dose, ma'am.
10 mg. 10 mg is
10 mg.
Yeah, 10 mg is the maximum. Maximum you're giving is 10 mg, correct? Yes.
yes.
That is the dose we give. Adrenaline, how much you gave, doctor?
Adrenaline actually we took 1 milligram diluted to 10 ml. Then after, with that, take 1 ml again diluted with 10 ml. Then we gave 20 to 40 micrograms.
Yeah. Actually, the adrenaline has got very good results, but we should be bold enough to give intracoronary adrenaline, which we, yes, we have to give, doctor. That's very good. And that's how we have gained the results. That's great, doctor.
Actually, the interesting scenario was we thought everything was a calcified lesion, but somehow we had a thrombus in that medial AD. We didn't expect that thrombus to form.
So one other thing, what you can do is instead of microcatheter, you can take thrombustor catheter. You can give first the cocktails and then you can simultaneously do thrombosection.
Actually, I forgot to mention, so we attempted thrombosection also with the thrombostat device.
So first time when you keep the thrombo catheter down, no, you can take out the thing and can give like a microcatheter all the cocktails and then you can suck.
Okay.
Actually, yeah, it's actually a very good case, sir. Actually, and your that thrombus been happened because of the calcium and the balloon dissection. That's why you had a thrombus and went down and all this problem, and it's a long segment calcified lesion actually. So and once you establish the flow, when you have a long segment calcified lesion, if it has been a balloon uncrossable, then we have to think about other modifying things. But here with the with the guide extension catheter, you could able to cross the balloon. But still, maybe either because when you see the OCT, there is a lot of calcium plates behind the that dissected segment. So probably retrospectively thinking, maybe the other modification technique would have been helped in this case. But definitely, its end result is very good actually.
Yeah, I too would go with Dr. Mohan sir because when there is a dog boning effect, to go high on the pressures will be especially in an eccentric calcium. It is there is always a risk of perf. So we need to be careful. We should have all the armamentarium at place, and then we can definitely do it. Of course, we had been very lucky, and patient is lucky. But always, when there is an eccentric calcium, severe dog boning, we need to go slow and be careful on that. That's so. But
And one
sometimes,
more, one more advice from my side is somebody is having this kind of long segment cases. Nowadays, the pre-dilatation balloon, even a NC balloon, which is available with the 20 millimeter, 25 millimeter length balloons. So we can have a controlled dissection with that long segment balloons, which can be useful in these kind of cases. So that is also been another option. Anyway, those who are been the beginners, it will be very useful actually.
and you mentioned that you had used the Apata balloon, no? Definitely, it has got an advantage over the other cutting balloons because it's made of these nylon blades, and the risk of perf is relatively less. We also use more of these Apata balloons, wherein the main thing is not because of the company, because of the nylon the blades which are made of nylon, which has got beneficial over the other cutting blades, where the risk of perf is slightly on the higher side. But whatever it is, we have to be very careful when using this and have all the covered stents and all the coils, everything at hand, because we shouldn't end up in a perf or anything. But well done, case doctor.
Kept rotablation, everything is ready, ma'am. But unfortunately, we had to use intracoronary relaxim, nicotindil, terafeban, everything. So, and ultimately, Aperta itself helped us to predilate the lesions well, and the stent was well expanded at the end of the procedure.
Yes. We are also now using more and more of this nylon blades cutting balloon, that is the Apeta, but definitely it has got beneficial effects. I do agree with you, definitely.
So that's a nice discussion. So we'll go to the third speaker. This is Dr. Vijesh from Arna Cardiac Care. He will be presenting the third interesting case. Over to Vijesh. Vijesh, are you there?
Yes, sir. So, are my slides visible, sir?
No, not visible. Yes, visible.
Good evening, madam. Good evening, sir. I thank Dr. Arnachalam, sir, for providing me this opportunity. I'll be talking about a case which we did in our center. The role of OCT in ultra low contrast PCA, which was a balloon non-crossable lesion, we did with a laser assistance. So this is our system. So, slides visible, sir? No?
Yeah, visible.
It's a 75-year male, which is a diabetic and hypertensive. He presented with ACS inferior wall MI. He has a known CKD, but he had a stent for an unstable angina, did in 2016. And echo showed region wall motion in inferior segments, and he had a normal LV function. So this was his angiogram. So the RCA can see the proximal part of the stent. The stent was a 3 cross 15 mm stent. The proximal edge of the stent had 100% ISR, and we can see a faint flow in 1/4 of the stent. And L6 was non-dominant vessel with like a borderline lesion in the mid part. And LAD also had an 50% lesion, but the acute was RCA, so we proceeded with angioplasty. So we wired the lesion, and the difficult part is we couldn't able to track the balloon. It was a balloon non-crossable lesion. We de-escalated the balloon from 2, 1, and 0.85 was the lowest balloon available on our shelf, and we tried with that. And we even tried Guidezilla for the support, but nothing was crossable. So what we have taken is a laser. So the laser catheter is a 0.9 catheter we used. Luckily, the laser crossed actually. We kept the laser in the proximal part of the native vessel first, and with the frequency of 45 and the repetition of 25, we did a blood lasing initially. So that gave the way, and it dislodged the thrombus, and the laser catheter went inside the proximal part of the stent. And inside the proximal part of the stent, we did a saline lasing, and we avoided contrast lacing this patient. Since patient was a CKD patient, we wanted to avoid the contrast load. And after doing the lacing, you can see in the last picture, there was still no flow actually distally. But what we can see is the laser did the work. the balloon was crossable actually. We crossed the lesion with the balloon. Laser actually modified the plug, and we were able to track the balloon. We initially tracked 1.5 balloon and slowly escalated to 2.5 and up to 3 NC balloons we did. So after that, we gave a good cocktail and low dose of tyrofiband and make sure that ECG there is no ST elevation, the flow was normal, and we took an saline OCT run. So as you can see in the left part, there was a saline run done, and these are the interpretations of the saline pullback. So this is the run. I'll again play it, pause and play. So this is the native part. What I have paused is the native part. The laser has produced dissections in the native part of the vessel. That is the first part, which was non-crossable balloon, non-crossable part. The laser has produced dissections in the native vessel. After that, you can see the stent comes. So this is the first edge of the stent, which has a calcium ring behind the stent. You can see that stent is here. Behind the stent, there is a calcium. So this is a heterogeneous pattern. This is, you can see, it's a whitish part here and it's a darker part here. So the morphology of this ISR is a heterogeneous thing. So as I go down, you can see a thrombus. These are the balloon dissections which has attracted some thrombus over there. But the laser also did its job. So these are all the lacing effects. So you can see, and this is the heterogeneous pattern. You can clearly see here. So the stent, in the distal part of the stent, when you take a 15 millimeter stent, the proximal first 10 mm of stent had heterogeneous pattern, and the distal 5 mm is more or less of a homogeneous pattern. So there was a clear landing below the stent. And the right side pictures, you can see there's eccentric calcium, superficial calcium, what we have mentioned, that is actually behind the stent. The location is proximal to the old stent, just in the proximal edge of the stent. The second picture, you can see neoatherosclerosis, which is a heterogeneous pattern, as I already shown. And the third thing to see is the EL of the distal vessel. Distal vessel EL is 3.75. I have told the stent they have deployed previously is a 3 mm stent, but the thing to note here is distal EL is 3.75. So that definitely is an undersized stent. So you can see here also. So this is the proximal part of the RCA. So you can see as you go in, this is the balloon dissection, used dissection. So these are the laser effects. So laser has the effect, the work of the laser is to modify the plug that is inside the stent. So you can see here clearly, the laser has done its work. And after lasing, we have done a 3 NC balloon. We accelerated the balloon to 3. So it has produced a little bit of lumen gain. So proximal stent edge lumen is 3.65. That is, this part is, the stent starts from here to here. So the 2 o'clock position, there is a sandwich of material between the stent. That is an neointimal hyperplasia. The EL is 4.15 proximally. And the distal EL is around 3.5 actually, 3.2 and 3.5. Again, mid part of the stent, there has a peri-stent calcium. You can see I have measured and shown here. There is a calcium nodule, which is behind the stent, which is inside the stent actually. Sorry, the stent starts here. So stent is like this. And the peri-stent calcium is more than 700 micron. It will be less likely to yield to balloons, but somehow it will give way through the laser. So lacing effects, how it will be in the native segments and how it will be in the ISR segments. This picture is native segment, you can see the dissection. Since it was a balloon non-crossable lesion, we were forced to do laser in the native vessel, which has produced a mild dissection. And our target is actually, what recommendation says is you should be very safe. It is very safer if you do laser inside the stent. So our target was to do laser inside the stent. Actually, the laser has done its work. Actually, you can see there are multiple dissections and multiple log modifications done after the lasing. So till now we have used only NC balloon, laser plus NC balloon. That's all we have used it till now. So you can see the log modifications all done by laser and NC balloons. So this is how the saline laser. One important thing what you have not to note here is when you lace, that is when you kept the laser catheter inside the stent, the guide positioning is very important. The guide should be coaxial. It should be fully engaged. It should not slip out. Suppose the guide is not engaging properly, it's not coaxial, means if you start lacing, if you will usually give laser for 10 seconds and give a pause for 5 seconds. During the laser for 10 seconds, if it slips out, you should be very attentive and you should stop the lacing immediately. So guide support is very important. As you see in this left part of the slide, we have taken a guidezilla for stabilizing the guide. Actually, the guide was not coaxial, so we took a guidezilla and stabilized the guide and did a saline lacing again with a higher frequency and higher repetition. So after that, with guidezilla support, we were able to track 3.5 aperta, and we modified the plug and the calcium segments which are being seen in the OCT, pre-OCTs. So we used some 5 ml of 2 ml to 3 ml of contrast for positioning the stent, and we limited the contrast since the patient was CKD patient, and we have deployed the stent. So after that, we have post-dilated with 3.75 NC. From distally, we will going to 12 and proximally more like at 18-20 atmospheres. So this is a post pullback. I'll freeze and show you. So this is the proximal part of the stent. This is a native vessel landing. Proximal landing is here actually. You can see some small motor proximally. So this is after this is the area of concern actually. So there is a tissue caught in between the stent and the previous stent, that is sandwiched between it. And you can see that calcium is behind it. Here spotty calciums are there. So the under expansion was around 80%. The expansion limit was 80%. There was some small under expansion, and you can see that these are tissue prolapse. That cup shaped things are tissue prolapse. The previous stent is here, and this current stent is here. As we go higher and higher with NC, there will be a more chance of still tissue prolapse that will lead to loss of lumen. So we have titrated and restricted the post dilatation, and we addressed only the malopposition. And you can see distally, and there was a less sandwiching between the current stent and the previous stent. So you can see around 20 microns of sandwich is being made. If the laser was not there, there could have been more sandwich material cut between the stents. So this is the final OCT pullback which I have shown you, and the right picture is as you see the stent, there is a under expansion, but as we see the OCT, there is a tissue collapse. In this case, you should titrate between going higher with NC balloons and accept what lumen we have got actually. So this case, we used a total of 20 ml of contrast. We used to contrast for 4 shots. That is after lacing and positioning of stent, and the OCT run. Since the guide was not coaxial, we were forced to use a 2:1 contrast. That is one part of the contrast and 2 part of saline. And finally, a diluted check is given. This is the final shot. You can see it's a well deployed stent with no stent thrombus, no edge dissection or no thrombus floating. So why to use LCA for ISR? It's an effective and safe debulking, allowing the potential for greater vessel and stent expansion. In addition to debulking, LCA also modifies the plaque, making it more amendable for the further stent expansion. The third thing is to decrease the potential placement of additional stents inside the stenotic stent. So previously we had presenters, we are saying that ISR was there, they think of a DEB. So if you're planning for a stent, you should shave off the material, that is atherosclerotic material should be shaved off as possible as we can. So laser definitely helped in this case to reduce the sandwich material. So the fourth thing is decrease potential risk of distal embolization. So as we do lacing, there are three types of lacing we do often. That is, one is the blood lacing. Second is a saline lacing. The advantage in the saline lacing is we keep on pushing saline at the rate of 1 ml per hour while laser is doing its work. So it reduces potentiality of a slow flow and distal embolizations. As the things get flushed off with the saline, it reduces the distal thrombus and slow flows. So when you think of ISR, the ISR should be dealt with the tissue inside the stent. That is tissue inside the stent. Removing the tissue has been the logical step for ISR treatment. Ablating the neointimal tissue and greater lumen, final lumen is the only thing that should be achieved. This could play an important role in lessening the endothelial and outer vessel matrix damage through a reduction of stenotic process that has been triggered by a medial and adventitial pathways. So definitive indications are instant rhinoceros for lasers, CTO transversable by guide wires, and long lesions more than 20 mm, lesions where balloon angioplasty, balloon non-crossable lesions like this case, and moderately calcified lesions, osteal lesions, and graft saphenous graft occlusions, and thrombotic lesions in acute MI. The red thing I have indicated is what we have done and experimented in our centers. We are still in the learning curve, and we have did some 15 to 20 lasers till now. And most of the thing we have did with instant restenosis ISR cases. And we have been lately started doing acute MIs that gives a very good results. Actually, we lace, we stent and come out. That reduces a slow flow and dissection. So lacing avoids a predilatation and thrombus shift and other things. So thank you for giving me opportunity.
Great cases, great case, doctor. Actually, in Indian Heart Journal, we have our own Dr. Damodaran sir, ISM sir, their publication of eczema ELCA in diffuse instant restenosis. It was a 5 cases series which was published in Indian Heart Journal, and the outcomes were good. And they've told that definitely the rates of the slow flow, distal slow flow and all was quite less, and the outcomes were good, but it was a total of only 5 case series recently published in the Indian Art Journal from Apollo. How many cases have you used, doctor?
Madam, sir will be in a good, better position to comment, sir. Arnachalam sir, please
Just
share
you
your
can,
experience.
you can stop sharing your slides.
Yes.
Madam, actually, we have done around some 16, 17 cases,
Great,
but
sir.
mostly 7 cases were with ISR only. And because we first want to play within net, because the problem is the saline lacing, the thing is, if you do it in a native artery, the dissections and perforation, that is what the strength of the laser when came in 1980s and then stopped. But this is the cool laser, intermittent pulse laser, and saline lacing. These 3 points makes the laser again a rebirth and taking a small niche indications in especially ISR and acute MI. So the thing is here, if you see in this case, what he was showing, the laser didn't cross totally the fully lesion. It only just modified the plaque and made the balloon to cross back. So this is the great advantage. Even the laser catheter doesn't cross fully the stent. We are able to take the balloon and can go that. Another advantage is here the disadvantage is this patient is CKD. Otherwise, if you do a contrast lacing, you can get a good lumen gain and more tissue ablations. Because the contrast lacing, what they are telling is saline lacing 30 to 40 atmosphere means contrast lacing is more than around 100 atmospheres the bubbles are produced. It is almost 2 times more than IVL. So the thing is it does a good work, but provided this patient had a CKD, so we are not able to do that contrast lacing. Otherwise in ISR contrast lacing can be done. Native arteries contrast lacing is still a off-label indication for and moderately calcium lesions. Otherwise, better saline lacing 1 millimeter per second. Second operator should flush, and 1 millimeter per second. The primary operator should move. And as he said, the guide there should not be jump. Otherwise, it will perforate the vessels if there is bends. So we should slowly do that. And 10 millimeter, 10 seconds you do lacing, 5 seconds automatically the machine goes for standoff. Then it gives a sound. Then you can start forward. So the main which you have to do slowly, then only you have a more diameter of ablation. And ISR, it is very safe. Acute MI, we have done 4 cases. And as he said, we are not used in acute MI, even calcium with thrombus. There is no need for aggressive predilatation with scoring or cutting balloons. You do lacing and do a NC, it expands well. And that is safer. That is what we are learning, just done only 16, 17. But it has its role.
Sir, 16 case is actually very good learning curve. But anyway, you will learn a lot with that, sir. The one more thing is that lacing the long segment, especially this case, begin the stent, there is a lot of calcium was there. So that is the reason why even if you have used contrast lacing, that would have been difficult for you that to get that calcium thicknesses. He has mentioned some of the areas which is it was looking like in OCT 500 600 microns more than that. Actually, that is the reason why you could not able to get the some more MSA at the end of the procedure actually. Even with this kind of cases, even IVL behind the stent, the calcium losing, it may not get happen because the calcium thickness is bit high. But this result is excellently very well. And the lacing the tissues inside the that lumen in the ISR, yes, definitely this has a very good role, the laser. It's a very good case. There's no question at all.
A lot of great insights from Dr. Arunachalam sir, Dr. Mohan sir, and the presenter, Dr. Vignesh. Vijesh.
Thank you, ma'am.
Thank you, sir.
From the 4th presenter is there, Arun Arokya Rajesh.
No, sir, actually, he's on duty today. He was to present from Omandurar, but he's on duty today with a hectic schedule. Next time, he'll be presenting, sir. I left mine bifurcation under OCT guidance. Yeah.
Definitely, madam. No problem at all, madam.
Yes, sir. Yes, sir.
Sir, anything, sir? Arunachalam, sir, any other points, sir? Because you are now almost close to 20 cases of laser. And
you can publish it, sir, because
he can do that actually.
Cases you can publish
Definitely.
it, a series of cases.
Yes, Ultrion 2. I forgot to tell actually. This he has done with Ultrion 2. You can see that in the single profile, you can see that lumen, what is the MLA, everything will automatically would get come, and calcium arc, everything will get come. So it will be easy for that to where to dilate, where not to dilate, where to ablate, where not to ablate, we can see very easily. So I forgot to mention
exactly, that. Exactly. We had one other case, a 79-year-old man with antral MI lysed outside and referred. But the EF was 35%. When we took an angiogram, there was a distal LED just close to apex was 90% lesion was there, 15 millimeter lesion, severe calcium. But the lesion is in the proximal LED with severe calcium and thrombus. So what we did is we just laced the proximal LED, and first we did with 2 balloon and then take a OCT and then we targeted one area where there was 270 calcium. So just the saline lacing and no aggressive pre-dilatation, we stented, and post-dilatation done NC. There was no much embolization, and the distal close to apex, that there is no occlusion of the LAD. I presented this case in CHIP. So that was very nice. So this calcium with thrombus combination, no, we are very afraid to use other calcium modification device like Rota or Orbital. There, this is one advantage of this laser. This
I think
calcium thrombus.
yes, sir, definitely. As you said, balloon uncrossable lesions, thrombus with some minimum, that is not very heavy calcium, not a nodule, some amount of calcium. I think laser has got a great role. So, apart from that, eccentric nodular calcium, I still doubted, because in one of the recent talks by Dr. Ramesh Dagubati, sir, who has got a extensive experience with the laser, what he said was, balloon uncrossable, that's a good option. But otherwise, for heavily calcified vessel, nodular calcium, he said it is still in the backstage, not in the front stage, because they've got since it is relatively new for us and relatively old, this thing for them with lot of experience. His personal comment was, for heavily calcified, laser is still on the backstage.
But
for
they are looking at a new laser catheter, madam, for this.
Yes, sir. Yes, sir. That is what I wanted to tell you.
If it comes, maybe it will tell whether severe calcium it has.
Yes, sir. Yes, sir. They are on the
mild to moderate calcium, it has the role.
It has a role. Yeah, for heavy calcium, I think soon a tool is under innovation.
Another advantage is that day we had one 32-year-old fellow who had a female as more than 3 days of MI. But when you look at the RCA, there was collateral. So it was a chronic thrombus. There we did lacing. There was no VF, VT, nothing, no pre-dilatation. We directly stented, and just post-dilated came. The patient EF was only 30%. It was a nice result. These are all some advantages. You cannot have all the things. This is some
certain, yes, sir. Subsets definitely it scores over the other things. Yes, sir. I think that was a great learning session for all of us.
Yes, madam. All of us, actually, it's a very good learning cases. Excellent case presentations, and we had a very good webinar arranged by Dr. Arunachalam sir, and it is very good, actually.
So I thank these Abbott people, and also Majula madam, Mohan, and the presenters, Shiva Palan, Dr. Vijesh, and Dr. Mohammad Aziz, and all. It was a great learning, and thanks to Ram, who is backbone of this thing, and to the audio team and this AV team of Abbott also. So thank you all.
Sir, just to add, sir, hi sir. Sir, actually, thank you so much, sir. Arunachalam sir, Mohan Mani sir, and Sisa Mary madam. Actually, we were really actually felt within 2 days how actually we're going to do such an activity, such an interaction, such a presentation and all. Actually, very frankly speaking, actually all three actually you made like that session completely live, deep dive discussion about that, all the from basic to laser completely actually thoroughly actually we learned from all three. Sir, actually it's an excellent this thing. And first of all, thank you so much, Arunachalam sir. Actually, I also got some opportunity to learn from you about the laser and the newer technology about Ultrion 2.0. Sir, actually, Mohan Mani sir also pointed rightly. Thank you so much, sir. Keep on. Actually, we will learn as a team from you all, doctors, and thanks a lot. And we will again actually meet in one more session. Thank you so much, sir. Yeah.
Thank you. Thank you. Thank you for
thank you, ma'am. Thank you.
Thank you. Thank you, sir.
Thank you.
Thank you, sir, man.